old can an advance directive be, whether a video or a document, and still be considered valid?
So David, do you have a clinical answer to that question? And then I'll give the ethical and legal answer.
The answer I would give is until it's rescinded, it's valid.
Yeah, that's the technical answer. From an ethics consultation perspective, what we would look for is evidence that the directive, whether it's a video or a document, contemplated the circumstance that the patient finds themselves in, either as a generality or in specific detail, and that there isn't any indication from family members or from treating clinicians that the patient changed their mind, or that we ought not to assume that a patient's advance directive about one circumstance would apply to a unanticipated circumstance, or the opposite. And the opposite is actually more interesting, because I had a consultation a year or two ago involving an individual who said, if I am suffering from a terminal illness, I do not want any care. I want to be allowed to die. And that patient had a stroke. Well, so what did the patient mean by terminal illness, right? We ought not to obsess about the medical definition of terminal or the medical distinction between illness and injury. Our job ethically is to get inside the head of the patient from all of the available sources of information and understand what the patient meant. This is a process that we describe in clinical bioethics as substituted judgment, right? You're projecting forward what you know of the patient's values in order to gain an insight as to what their wishes would be concerning a circumstance that they did not describe.
Thank you.
Our next question is from fellow advisory board member Peggy Batten. She's wondering, suppose a patient newly diagnosed asked you for your advice about how long it makes sense to continue with Alzheimer's, or where it might be best to stop if you wanted to maximize the amount of, quote, good life left, but wanted to avoid the worst. What would you say to that person?
That's an invitation for a broader conversation about what matters most. And then a conversation ensues where we talk about, what do you worry about the most? And what's important to you? What do you care about? What do you fear as you live with X diagnosis? And it's the answers to those questions that help me give a response to that. Until then, it's me listening and clarifying and asking other questions that help unpack what is most important. So that's a palliative care conversation.
For all of you out there, that is the kind of question that you have to anticipate from a philosopher who has spent most of her professional life thinking deeply about these questions. Peggy, I'm glad you posed that question to Dr. Gruenewald first, because I find your questions very challenging and very thoughtful. I would add this. I think the question within the question is, can I identify a moment when I have achieved the most enjoyment of my life, before I reach a point where I am not able to express or enforce or activate a decision that I don't want to wind up where I don't want to be. And to David's point, that has to be a bigger conversation, because obviously as a technical matter, we have no way of knowing when is the last moment of some quantum of joy, right? That's the dictate of my advance directive. When I am unable to express myself and experience joy, I want all but pain care withheld. Knowing when that is, that's the tricky part. And that's what requires a conversation between a patient and their family member and their surrogate and their doctor and their resident philosopher. That's the only practical way of getting as close to that boundary zone as we are able to achieve.
And I would add that there may need to be further conversations as circumstances change. And if the person is no longer capacitated at that point, then the conversation is with the surrogate, with the person who will speak on behalf of and be the voice of the person.
I think the point Peggy wants all of you to understand is that even after you've lost your decision-making capacity for a particular decision, you still have values, you still have priorities, you still have preferences. And the notion, for example, of narrative ethics, something we're going to be discussing at an event next week with Danielle Spencer, is the notion that even when you lose your decisional capacity to make the decision that needs to be addressed in a particular moment, you still have the ability to direct that there be a consistent narrative thread through your life, and that insight guide how care decisions are made by your surrogates and by your caregivers.
Thank you both. I'd like to conclude with a question from our very own Dr. Timothy Quill. Even when patients still have capacity, they may not be terminal enough to qualify for medical aid in dying. So stopping life support and voluntarily stopping eating and drinking seem like the only options, which may require acting before you really want to. If you do wait, are there any ways you can guarantee that people will act on your behalf?
So Tim and I did a program, it was either a week ago or a month ago or a year ago, it's all a blur, on palliative sedation. And if you're interested in the subject that is suggested by Tim's question, I urge you to take a look at that recording, which is available on the Completed Life Initiative website. I think the answer to your question, Tim, is the answer that David gave earlier, and that is to line up your team, and your team has to be your entire family and friend group and whomever you've selected as your surrogate and your backup surrogate. And you have to make sure, for example, through videotaped messages that can be viewed by your surrogate and your caregivers, and maybe even the administrator of your long-term care facility when you are no longer able to speak for yourself, so that all of those individuals can see who you were as a person and what your priorities are. I hate to say it, but if you are concerned about winding up in that situation, in addition to lining up a highly qualified and committed and tough clinician, you need to line up your surrogate and your ethics consultation resource, and yes, a lawyer who understands this complexity and has a fidelity to the values of patient independence and the duty that clinicians have to exercise their skills and their judgment and their authority with humanity and humility.